Welcome to this video presentation for CPD on October the 8th, 2012. Today we will be looking at the ligaments of the odontoid peg. The four ligaments we'll be looking at are the apical ligament, the alar ligaments, the transverse ligament and the cruciform ligament. Here we are having highlighted in red the apical ligament arising off the odontoid process and attaching onto the anterior rim of the foramen magnum. The image on the right shows a posterior view of the small apical ligament. The apical ligament is absent in about 20% of people. It is approximately 7 mm long and 5 mm wide. With the head in the neutral position, the apical ligament is lax and becoming taut at about 15 degrees of flexion or extension. It appears to have no influence on C1, C2 stability, and we can see that labelled the apical ligament and the top of the sagittal cut. The next set of ligaments we'll be looking at are the alar ligaments. Here we have again a posterior view of the area of C2. The alar ligaments are about 10 mm long, one on either side of the peg, and these attach out to the occipital condyles. These limit axial rotation. They are most vulnerable to injury upon rotation with hyperflexion. Here in this posterior view of the odontoid process, we can see arrowed the two alar ligaments. Here we have an avulsion of the occipital condyle. The actual alar ligament has become so taut under pressure that it has actually avulsed a portion of bone off the occipital condyle. And we'll see some better pictures of this in upcoming slides. Here we have a good example on these CT cuts of avulsions of the actual occipital condyles by the alar ligament. I have highlighted in the actual axial and coronal cuts on the right the alar ligaments in blue. The next ligament we'll be looking at now is the transverse ligament. This is a thick fibrous ligament that transverses the ring of the atlas and holds the odontoid peg up against the anterior ring of the atlas. And here I have it highlighted in green. Some interesting facts about the transverse ligament. Hyperflexion can cause rupture or avulsion at the bony insertion points on the atlas, and due to the strength of this ligament, the odontoid peg usually fractures before the ligament actually ruptures. Approximately 85 kilograms of force is required to rupture this ligament. Congenital laxicity is common in Down syndrome, and infective changes can also produce laxness in this actual ligament. Here we have two views, a posterior and lateral view of the transverse ligament area. The transverse ligament are actually highlighted in red, and on the lower right image we have a lateral view showing the thickness of the actual transverse ligament, and we can see how it's up against the odontoid peg. Here we have some diagrams signifying the rupture of the actual transverse ligament, and we have two types which we have classified by a name called under Dixon, which we have the Dixon type 1, Dixon type 2. The one is actual full section torn out in type 1, and as we can see on the right in type 2, that where there is actually a bony avulsion. Treatment of this is for a C1, C2 bony fusion. Here we have quite a good example. We have a CT cut with a bony avulsion of the transverse ligament insertion. And on the bottom right hand corner we actually have a specimen with a totally torn transverse ligament, reminding ourselves that 85 kilograms of force approximately is required to produce this, which is quite a significant amount of force. An interesting thing to note that with the transverse ligament is prone in some older people to calcification. Here we have on the left a calcification of the transverse ligament, and on the right we can actually see quite a significant sagittal cut where we have severe calcification to the point of producing compression on the actual spinal cord. The final ligament we'll be looking at today is the cruciform ligament, and this is made up of the horizontal component being the actual transverse ligament in itself, and then we have the superior and inferior bandings. The superior band, which we have labelled, is the thicker of the two bands, and it rises from the fibres of the transverse ligament and attaches onto the occipital bone. The inferior band is thinner, and that arises off the transverse ligament and attaches to the posterior surface of the axial body. Its function is to stable the entire complex. Just some interesting pediatric considerations. The ligaments are relatively immature at this age and result in an increased chance of upper C-spine injury. As a child ages, the fulcrum of the actual spine mobility moves from C1-3 down to a C5-6 area. The vertebral column actually is more elastic than the actual spinal cord in itself, and when a sudden force is applied to the actual cervical spine, elongation of the vertebral column is not actually matched by the spinal cord, and this can result in actual cord contusion, compression or vascular injury. If one can draw an analogy, it would be like having a solid stick inside a concertina, where the actual concertina moves in and out, but the stick does not move at the same distance. And this can result in all forms of trauma to the actual spinal cord. Thank you for watching this presentation on ligaments of the odontoid peg.